Hello and welcome to my presentation on student perceptions of medical educational modeling and radiologic technology education. My name is Heather Schmuck and I am a student in the Doctor of Education program. So this research was completed as part of a larger research study submitted in partial fulfillment of the Doctor of Education degree at the University of Southern Indiana. My dissertation was on student perceptions and considerations for medical educational modeling and radiologic technology education. I defended that presentation on January 21st. I would like to acknowledge the following individuals for their assistance and service on my dissertation committee: my chair, Dr. Bonnie Beach, and my colleagues, Dr. Aaron Reynolds and Dr. Heather Moore. I'd also like to thank the University of Southern Indiana for the employee benefit, which allowed me access and continual pursuit of higher education, and the Indiana Society of Radiologic Technologists for their general scholarship, which allowed me to be able to finish the degree. So in many of the healthcare disciplines, there exists a learning by doing philosophy. Most health disciplines deal directly with patients and have a high volume of patient contact. Many of these disciplines require physical contact in order to provide the necessary health care for the patient. In thinking about the training and education of future healthcare professionals, educators need to assure that new graduates are competent. This question does arise as to who or what these students should be practicing their skills on. Some literature suggests the use of mannequins to simulate a patient, but due to the nature of it being a mannequin, some of the realism is lost for translation to a practical setting. There has been a rise in the use of standardized patients, which are usually paid volunteers who act as a patient for students to learn various skills requiring communication and physical touch with. This can obviously be costly for healthcare education, depending on the number of competencies needing to be demonstrated before graduation. So a more practical approach commonly used in many disciplines historically is peer physical exam or medical educational modeling. This is the use of peers within the same cohort acting in the patient role for their peers to be able to demonstrate various clinical skills upon. These skills can be simple tasks such as questionnaires or taking blood pressure to more complex tasks such as physical exams or intravenous access. Previous literature studies have been fairly limited in the disciplines included in the evaluation of medical educational modeling and have been mostly focused on the physician or nurse training. There was no evidence found in the literature focused on imaging sciences. The literature previously published does include a host of benefits associated with this practice, including cost savings, having a normal anatomy figure to learn from, and shielding real patients from incompetent students as they learn their skills. Along with the many benefits, many concerns have been surfacing related to the practice of medical educational modeling. Most notably is the student discomfort with the practice expressed in literature for reasons such as gender differences, culture, religion, and issues of coercion in the practice. So the literature clearly makes an argument that not all students are comfortable with this long-standing practice. However, there has been little research into what this practice means for students enrolled in allied health programs such as the imaging sciences. The literature makes clear suggestions on various demographic factors of students that may have issues with medical educational modeling and how these feelings may change over time as they become more competent in their fields and understand the why behind this practice. The literature also makes a distinction between students' perceptions and comfort levels with medical educational modeling. How students perceive and understand the benefits of this practice can be different than their comfort level with engaging in the practice. Looking more specifically at my field of imaging sciences, we are a very hands-on profession. We learn by doing, so much of our field involves positioning patients for appropriate image acquisition and involves a high volume of direct physical contact. These skills must be learned over time, but again, who should these skills be practiced upon? While other fields such as physician training and even nursing were identified in the literature associated with the practice of medical educational modeling, no studies have previously been conducted examining how imaging science students perceive the practice of medical educational modeling in our profession, or what their comfort levels are with this pedagogical practice. So this quantitative research study was part of a larger research study for a dissertation which sought to examine the perception and comfort levels of radiologic technology students participating in medical educational modeling as part of their educational programs in Joint Review Committee on Education and Radiologic Technology accredited Bachelor of Science Radiography programs in the United States. Using a cross-sectional survey research design with quantitative methods, I wanted to study the students' comfort levels with the various roles undertaken during medical educational modeling by the student, such as how comfortable they are acting as the simulated patient or the performing technologist with a peer in their cohort, or what their comfort level is when a teacher takes on the role of technologist while they are in the simulated patient role, or even what their comfort level was with simply observing medical educational modeling taking place. I collected various demographic factors to be able to identify if any factors impacted the comfort levels in any of the roles or the perceptions of medical educational modeling, and I also wanted to give participants the opportunity to provide open-ended responses related to what they felt were benefits, drawbacks, or opportunities for improvement with the long-standing practice of medical educational modeling. I hope to learn of any significant factors that should be taken into consideration in the education of future imaging science professionals in order to provide information on how educators could transform their approach to teaching the skills necessary for students to become competent practitioners. So my full study focused on 6 specific research questions related to students' perceptions and comfort levels with medical educational modeling. For this presentation, I will be focusing on the following questions. What are radiologic technology students' perceptions of the medical educational modeling experience as a pedagogical practice? What demographic factors influence radiologic technology students' perceptions of medical educational modeling? And is there a relationship between roles of radiologic technology student participates in medical educational modeling experience and the perceptions of medical educational modeling? So coming from a quantitative paradigm, I developed a research instrument to examine medical educational modeling through a survey response. This survey, known as the Student Perception of Medical Educational Modeling, or Spmem survey, was combined from 3 different surveys found in the literature and combined into one survey focused on comfort and perception of medical educational modeling in the imaging sciences. The survey instrument included demographic factors for further analysis, as well as a section for open feedback to gain further perspective from the quantitative responses. As this was a new survey instrument combined from previously validated survey instruments, it was prudent to conduct a pilot study to check for validity and reliability of the instrument before proceeding to a full study. My pilot study participants were pooled from a sample that could be easily excluded from the full study. Of the initial survey requests, 24 completed surveys were returned, which constituted 69% of the total pilot study population. This population came from a mix of demographics and backgrounds and provided a good sample population similar to what the full study population would be. I established face and content validity by sharing with other imaging science educators who are familiar with the research design and adapting questions accordingly. I established construct validity across perception and comfort of medical educational modeling by conducting a Pearson R correlation among the survey items for comfort in Section 1 and for perception in Section 2 of the survey. All items were significantly correlated to the total score of each construct and were therefore deemed valid. Reliability of the survey instrument was confirmed through obtaining a Cronbach's alpha on each scale for the survey. Results demonstrated a Cronbach's alpha of 0.859 or greater on all measured items across the comfort and perception scales, indicating reliability of the survey items with no deletions needed. So this slide is just a visual representation of the various parts of the Spmem survey instrument. As previously stated, the Spmem survey contains 4 main parts. This presentation is focused on the second portion of the survey, which includes specific survey questions related to the perception scale. The perception scale is a measurement of perception with responses from 0 to 4, from strongly disagree to strongly agree, respectively, across 8 different questions on the participants' perceptions of the benefit and appropriateness of medical educational modeling. This section was adapted from a previous validated survey instrument to fit the imaging science profession. Additional parts of the survey included asking participants the number of times they have volunteered to be a model for the teacher and the number of times they have volunteered to be a model within a group of students, along with their preferred composition of student groups for peer educational modeling to possibly contextualize responses on the perception and comfort scale selections. And then the final section of the survey focused on demographic content, including information on age, gender, race, religious affiliation, body mass index, and general outlook in terms of conservative versus liberal. These demographic factors were selected based upon information collected through an extensive literature review on the topic of medical educational modeling. The participants' overall enrolled program length and completed length, as well as clinical exposure, was also collected based upon studies indicating that students who have more exposure to medical educational modeling in the clinical environment are less apprehensive and more accepting of the pedagogical practice due to the perceived benefit. My demographic responses were placed near the end of the survey to help alleviate response fatigue. The survey also included an area for participants to provide descriptive feedback on the practice of medical educational modeling. This section asked participants to respond only to items for which they had strong feelings and included a focus on benefits, drawbacks, and suggestions for improvement. There was space provided to allow an opportunity for feedback on the general practice of medical educational modeling when participating as the simulated patient or technologist and when participating as the model for the teacher in front of peers. A lack of response in this section did not eliminate the participants' entire survey from inclusion in the data analysis, since this section was aimed at obtaining descriptive statistics on strongly held beliefs about medical educational modeling as a pedagogical practice. So after validating the survey instrument, I obtained IRB approval for the full study and distributed the survey via email to the publicly available email addresses of all JRC ERT accredited bachelor level directors in the U.S. In my email, I asked for the program directors to distribute the survey to students if they use medical educational modeling within the program. I assumed that there were approximately 60 students per program in the U.S., as there was not a best mechanism to collect this data, since all programs vary on enrollment start and end dates. This estimation led to an approximate potential study population of 3,000. I plan to have the survey available for a 2-week time frame and sending reminders to the program directors on day 5 and day 12 to remind students to complete the survey. All survey responses were collected within Qualtrics, then downloaded to SPSS for analysis. So in the study time frame, 74 responses were collected, but 7 had missing data points in section 1 or 2 of the survey. These were eliminated to prevent error in overall comfort or perception score calculations from this part of the survey. This left a total of 67 total surveys, which only represented approximately 2.23% of the total estimated population. As this was significantly lower than an expected population, I conducted a wave analysis between weeks 1 and weeks 2 of the survey timeline, as recommended in the literature. According to Airy from 2019 and Ray and Parker from 2014, if no major differences exist between these 2 weeks, it can be assumed that the responses are representative of the entire population. Wave analysis was conducted across each role and each exam. For brevity, only the overall results of this test is presented here. In conducting my wave analysis among the comfort in the various roles of medical educational modeling overall, no areas of significance were found, and it was therefore assumed that even with my low participant response rate, the results may be considered representative of the whole population. Only one area of significance, lower leg and foot as a simulated patient for same gender peer acting as a technologist, showed significant differences between weeks 1 and week 2 of the survey. So my data analysis is broken up across the 3 different research questions for this presentation. So research question 1 examined students' overall perceptions of medical educational modeling. And to analyze this question, mean responses across all 8 perception questions from the survey were collected, keeping in mind that the first perception question was reverse coded to align with the 7 other positive statements. So the overall perception of medical educational modeling was positive, with a mean of 3.43 out of 4. The next research question for this presentation focused on demographic factors impacting the perception of medical educational modeling. The overall perception score was used to examine differences across any of the demographic factors under examination. So in examining the perception scores, the skewness and kurtosis revealed that parametric testing was not appropriate. So I therefore utilized the non-parametric equivalent to the ANOVA of a Kruskal-Wallis H test to examine the student perception across the various demographic factors. So in examining the demographic factors in relation to the perception of medical educational modeling, areas of significance among the different demographic factors were noted in religion and with BMI. Each of the demographic factors are displayed in the next few slides. So overall mean perception score across gender varied between 2.25 to 4 for each demographic category. Median perception scores across gender revealed no statistically significant differences between the groups. The majority of participants indicated their age to be within the first 2 categories, and comparing the medians across the different age groups again yielded no significant differences. And of the various religious categories selections available on the survey, only 8 were selected by participants. The majority of participants selected Christian, while Catholic and nothing in particular were the next most popular choices. Comparing the medians across the different religions yielded a statistically significant result of p equaling 0.011. So pairwise comparisons were performed using Dunn's procedure. Significance values were adjusted with a Bonferroni correction for multiple comparisons. This post hoc analysis revealed no specific adjusted statistically significant differences in median perception scores of medical educational modeling amongst the various categories of religion. These significant findings disappeared with the Bonferroni correction, most likely due to the low sample sizes within these populations. According to Vanderweel and Mather from 2019, this effect can happen when small sample sizes are utilized in pairwise comparisons, as it is considered overly conservative in applying corrections to calculate significance. So basically what this means is that due to some of my religion categories having small population numbers, the significance found was not really significant with correction. So looking back at the initial mean ranks of the data, it is clear that both Muslim and prefer not to answer categories had a much lower mean ranks included in the perception score, as well as much lower number of respondents, which may be causing variances in the significance calculations, while agnostic and Mormon categories had much higher mean ranks, along with a lower number of respondents. So these factors combined may be used to explain why some of these initial significance levels increase with the Bonferroni correction. So moving on and examining perceptions with Outlook, no significant differences were found amongst the medians of Outlook. And comparing the medians across the different BMI categories yielded a statistically significant result. So again, pairwise comparisons were performed using the Dunn's procedure, and significant values were adjusted with Bonferroni correction for multiple comparisons. This post hoc analysis revealed an adjusted statistically significant difference in median perception scores of medical educational modeling between the categories of overweight and healthy weight. There was no significant difference amongst the preferences for group composition for perception scores, and this group composition is referring to the lab groups and basically how do students choose to or prefer to assemble themselves into lab groups. An examination of the differences among the groups of length of exposure, how long basically have they been using medical education modeling in terms of perception score, also revealed no statistically significant difference. And due to the skewedness of the data set, the Pearson-R correlation was no longer deemed appropriate for this research question, and the non-parametric equivalent of the Spmem rank order was conducted to determine the relationship between perception of medical educational modeling and role participation. So examining student perception of medical educational modeling and the comfort score in the various roles of medical education modeling, 3 areas were found to be statistically significant. A statistically significant positive correlation between perception of medical educational modeling and comfort score as a simulated technologist with a different gender peer as a simulated patient. And then there was also a statistically significant moderate positive correlation between perception of medical educational modeling and comfort score in the role of simulated technologist with same gender peer and in the role of a patient for an instructor of a different gender. None of the other gender and role comfort score combinations produced any significant correlations with the corresponding perception scores. And finally, frequency counts of the number of comments submitted for benefits, drawbacks, and suggestions for improvement on the practice of medical educational modeling from Section 4 of the survey were analyzed to further evaluate the overall participant perceptions of medical educational modeling. Results indicated that 67 total complete surveys had 97 comments submitted overall by participants among the various roles and general practice of medical educational modeling. Almost 65% of the comments submitted were positive, while only 26% of the total comments were negative on the practice of medical educational modeling. Comments submitted as opportunities for improvement represented 9.28% of the submitted comments. Many of the positives revolved around learning the patient perspective, gaining confidence in being able to help fellow peers develop their skills, and the most repeated negative comments relate to the inability to observe the exam if you are in that patient role for either a peer or the teacher, and also the lack of opportunity to practice. The comments surrounding the general practice of medical educational modeling were pointed at ensuring balanced participation with the practice in the educational setting. So some of my limitations included access, sampling, response rate, and paradigm. I did not have access to the approximate 3,000 JRC ERT accredited bachelor degree programs Radiologic Technology student email addresses to directly recruit individual participants, and I had to rely upon program chairs to forward the recruitment communication from me to the respective students. This may have significantly limited the number of available participants' access to the survey. I chose to use purposive sampling, which is a form of non-random sampling, presenting the limitation of the inability to potentially generalize the results beyond the group of participants at the specific time of survey completion. While bachelor's degree radiologic technology students were the intended population for the survey, other imaging modalities within the imaging sciences, such as diagnostic medical sonography or magnetic resonance imaging, may have also been a part of the bachelor's degree program surveyed with similar characteristics to radiologic technology students. Additionally, due to the nature of online surveys, response rates were expected to be low, further limiting the study's generalizability across the entire population. A major limitation of the study was the small sample size utilized for analysis. While statistical analysis was utilized to demonstrate the validity of this small sample size, having a greater number of respondents may have produced different results. Another limitation that may be related to the small sample size was the skewedness of the data. I initially planned on using parametric tests, which may be considered more robust for interpreting findings, but due to the skewedness of the dataset, non-parametric testing was deemed more appropriate. In some categories of the demographics also had relatively small or non-existent sample sizes for representation of the group under examination. While statistical measures were followed to correct for these discrepancies, this could lead to potential bias in interpretation of the findings from the study. When examining the demographic factors for this study, it is important to note that not all potential demographic factors that may influence the practice of medical educational modeling were collected or analyzed for this study. Additionally, as I had to rely on educators to forward the survey onto potential student participants, all student perceptions of medical educational modeling may not be represented within the study due to not having the survey forwarded for whatever reason. The timing of the survey distribution and distribution method of electronic mail may also have played a factor in limiting the study population. As the study was conducted during a spring semester, many programs and students across the nation are preoccupied with other tasks related to program completion, graduation deadlines, and preparing for certification exams. These important tasks may also have overshadowed the request for participants. Lastly, the qualitative perspective of medical educational modeling was not analyzed or discussed for this study. Understanding the why behind the numbers may potentially shed further light on the continued practice of medical educational modeling. So, medical educational modeling is viewed positively by the majority of students in the imaging sciences. Students' perceptions of medical educational modeling improved with longer exposure to the practice. Considerations should be given to the demographic factors that produce significant differences in the student perception with medical educational modeling. Specifically, educators may want to examine student group composition in relation to genders, BMI of participants, and age and religious beliefs of group participants. This study found significant differences in the various roles when gender was switched back and forth, which is noted by many in the literature as being a potential hindrance to learning. This could be beneficial to ensuring a positive student experience in the laboratory practice utilizing medical educational modeling. Imaging sciences programs, or any programs for that matter, that utilize peers within the cohort should create policies specific to medical educational modeling if this pedagogical practice is used within a program. It would also be a good idea to review all demographic factors presented in this study and how they may relate to one specific program, even though many of the results of this specific study were not significant. There were many factors that may have contributed to a lack of significance. While the imaging sciences is a very hands-on profession, this study revealed that most students perceive this practice of medical educational modeling positively. There were a few areas of concern that could warrant further investigation and should be considered. This study could be repeated to obtain a larger population in order to validate these findings. Another group, such as examination of associate degree level programs, could be used to further explore the perceptions of medical educational modeling in the imaging sciences. And other demographic areas could also be considered or examined, such as consent or specific body regions of concern in the comfort and perception levels of students, which would also help to further the knowledge and understanding of this pedagogical practice. So that's the end of my presentation. Thank you for viewing this presentation. If you have any questions regarding this presentation or this research, I provide my email at the bottom of this screen. Thank you.